All right. Wanted to talk about cervical-thoracic deformity. Unfortunately, these we look at a lot of parameters. We have a lot of patients that we're trying to do the right thing for that may be coming in with various levels of function. Unfortunately, these are largely a lot of these I think are iatrogenic. We'll talk about some of the other reasons that you might have patients that come in with these problems. I think a lot of our focus, we didn't talk a lot about cervical deformity today. That's a whole separate topic that we can, maybe breach a little bit in more detail next year. But whenever you're doing lumbar deformity or cervical deformity, there's always the opportunity to have issues at the cervical-thoracic junction. And I think, I've definitely struggled with some of these cases, and I think they're very important to make sure to see what's worked. And I would love to hear from you guys what's worked in your hands as well. As we mentioned, the majority of what we focus on is cervical and lumbar because that's what's most common. But it can be confused with other spinal pathologies. If you do have cervical kyphosis, that could be generated from thoracic kyphosis further down as opposed to primarily in the cervical spine. One of the things that's very common is ankylosing spondylitis. People can have fractures. They go on to heal into some very aggressive kyphotic deformities. Some of these can be very flexible. Camptocormia, in the setting of neuromuscular disorders, or soft tissue disorders where these are very flexible spines where patients are in, they may walk into your office in an extreme kyphotic state, but when you put them on the table, they correct pretty significantly. And I think it's very important to make sure to examine your patient in terms of the flexibility. And I think one of the things that may be valuable, we talked about bending films and how in adults we're kind of moving away from those a little bit. But sometimes just the standing views that you're getting in whether it's a long plate or an EOS, and then you may have a CT or an MRI where they're supine, or some people even get just supine films. And looking at that difference, that can give us an idea of how flexible these patients are. Obviously, post-traumatic deformities, and I think the majority, the couple cases that I'll go through today were iatrogenic. But anytime we're doing long segment fixation, proximal and distal junctional failure are unfortunately very common. Post-laminectomy kyphosis is, I don't know a whole lot of people still doing, just standalone cervical laminectomies, but these patients do show up in my office from time to time. And then, abnormal lumbar alignment that's compensated for through the upper thoracic spine. As we mentioned before, there are countless parameters that we can measure in order to try to quantify this. I think that for me, the main question to ask is, how functional is the patient? When someone comes in and they can't look at you in the eye, they've got a significant problem. And you don't really need to measure that by anything quantifiable to know that they're debilitated by that deformity. But I do think that the T1 slope is very valuable in terms of if there is a cervical malalignment, it may be coming from a thoracic deformity, and the T1 slope can really clue us into that. So these are three very different looking cervical spines. So there is cervical deformity here, whereas over on that panel C, we're looking at, this is a study by Chris Ames, where looking at the different causes of that cervical deformity, where on the right, it's really coming from something further down in the thoracic spine and probably more neuromuscular, whereas over on the left, it's more of a pure cervical deformity. And then also from our ISSG group, these are extremely different T1 slopes, and that's because there's different underlying pathologies here. And so they kind of standardized it to this T1 slope is the cervical lordosis equals 16.5 plus or so T1 slope minus the 16.5 plus or minus 2 degrees. Again, really quantifying what we're seeing here. And we know if a patient has a neurologic compromise, we need to address these problems, but what are our goals? So these can give you, some sort of guide into what we're doing surgically when we do need to fix these problems. So posterior column osteotomies, we talked about earlier in the course. Pedicle subtraction, I think is definitely something that can be valuable in this setting. ACDF can be challenging depending on how far down that deformity is, but on the appropriate patient, I think knowing that you can do an anterior inner body to restore some of that anterior column, I think can be helpful. We'll talk about an intradiscal osteotomy a little bit later in the case, which is, somewhere in between our corpectomy. And, we'll talk more about the rail technique as well. I think these are all tools that you want to have in addressing these cases because in the middle of the surgery can be quite challenging. Other intraoperative considerations, sorry, skipping ahead here, but the bivector traction and intraoperative manipulation of the skull. We'll go through a couple techniques there, but just wanted to give a quick plug. Sorry, we're moving too quickly here. Thoracic PSO, again, I think is a very valuable tool. This was a case series where they were looking through, 25 osteotomies in 15 patients with long-term follow-up. The main thing I wanted to address here is that, up in the proximal thoracic spine, even though you're doing a PSO, they're only getting 10 degrees versus getting, 24 degrees in the distal thoracic spine. Just knowing that that's going to be fairly limited in terms of the amount of correction it's going to offer you. And if you do want to get more correction, you may need to be looking at a full VCR or multiple PSOs, and what do you think is going to be in your patient's best interest in terms of what you're fluent with and how quickly you're going to get to your surgical goal. Great study from Alekos and Dr. Gupta, the rail technique. Again, when you have someone who may come in with osteoporosis, this is a great step-by-step, technique on how to distribute the correction through multiple screws instead of really pulling through screws. You're just going to rip those screws out and end up with a bigger problem. So this technique kind of goes through how to distribute that over the course of multiple smaller movements through multiple screws in order to maintain the integrity of your construct. Unfortunately, here we are not fancy. We don't have these, pneumatic head movement. I think this can be very valuable in the surgery. If you need to use a Mayfield, scrub out and move the patient's head. Also, this bivector traction. This is in this TAN study where they kind of go through how to do it, but it's fairly straightforward. You can place the patient in a little bit of kyphosis with traction here. Then once you've done your posterior releases, anterior reconstruction, if you're going to do that, gotten your movement back, you can switch the weight over to that extension vector that's going to pull the patient into more lordosis. I actually prefer to, scrub out and physically move the patient's head. If you're pulling them up just by pins, that can be a little bit stressful on the skin. So I prefer to bolster up that, face pillar or whatever you're using. Sometimes you'll even need to bolster the chest in order to get that correction. And it's, not just the hardware that you're placing. It's not just pulling on the head, but also, patting the patient. If you have a pretty high angular correction you're trying to obtain, then you probably need all of those tools at the same time. I think it's important to talk about post-operative complications. Again, this is looking at all complications, major and minor, when we're going from a combined approach, approaching 80% complication rate. Again, when you're looking at smaller things like dysphagia and minor transient neuropraxia, that's very important that your patients understand this. Again, I know most of these are not elective cases, but very important to have that discussion with patients. And again, low-grade and high-grade osteotomies, really want to focus on that neurologic complication. 20% are going to have fairly significant neuropraxia with these high-grade osteotomies. Doing your best to minimize those when possible and making sure your patient is aware of the possibility that it could happen. So just wanted to go through a couple cases here. This was a case that came from the community here. She had a T10 to pelvis fusion that was then revised to a T4 to pelvis. Lots of rods there. We know we love our multiple rod constructs in this room, but I think when a patient has had multiple failures, I think maybe that was coming from this PILL mismatch is about 20 degrees here. Although her lordosis looks fairly good, she does have a very high PI. And so, unfortunately been kind of chasing this. So she showed up in our emergency department with, fracture dislocation at the T3-4 junction and was paraparetic. And so, again, this is not an elective case. It's not a severe deformity, but that spondylolisthesis is significantly compressing the cord, and it really forces us to address the problem. So in this case, I chose to use an intradiscal type osteotomy, and again, that's something where there is significant bone stock still remaining on that anterior column. So we're doing a release through the posterior elements, and instead of removing that posterior aspect of the pedicle and doing a PSO, we're actually able to put a expandable cage. This is a lumbar interbody type cage and restore that anterior column, and then go through those movements where we can get the patient back into alignment and stabilize her up to the C2. We had talked briefly about going just up to T2 possibly, but I felt that given her multiple failures, that this was going to be a much more rigid ending point to go to C2. Again, now we can see that lack of lordosis has really left her a little bit sagittally imbalanced, but she has been able to walk again, which is the main goal. And if she, this is her first post-op x-ray, but, if she is struggling, we can consider doing a PSO to really correct the underlying problem that was the start of all this. But just in the meantime, in the damage control surgery, really getting a robust construct across that cervico-thoracic junction. This is one of my patients who had a primary cervical deformity. So you can look at that T1 slope, very upright, very functional lady, was losing function of her hands primarily due to this myelopathy. And we did a front back reconstruction for her. She did very well. And about 1 month post-op, she fell in her kitchen and had severe pain. Fortunately, was neurologically intact, but came back with this severe kyphosis at the distal junction. And you can see there's really not much vertebral body left in that anterior column. So we chose to do a full vertebral resection and use an expandable cage in order to restore that anterior column. One of the things I think was very valuable in this case, I had never seen it before, but this was at the T2 level. And sometimes some patients can have different variations in terms of their innervation of the intrinsic muscles. So on the patient's left, the T2 nerve was firing the intrinsics. On the right, it was not. So fortunately, we were able to take that right-sided T2, even though you would expect it would be T1. She did have contribution from that left-sided T2. Fortunately, we were able to get this cage in safely by using a right-sided approach and reconstructing her anterior column. She's actually been remains working and is very functional despite this big construct. We were able to kind of salvage that, fortunately, without any neurologic deficit. So again, just wanted to go through some of these very challenging cases and, some of the things that have been helpful to me, because as deformity surgeons, these are problems we are going to see, whether we like them or not. Thank you.
Hey, great. Do you mind going back? Sorry, I keep going back to old slides. That
Yeah.
case that you revised from the outside hospital. Alekos, Dr. Theologius. So this is beautifully salvaged. Go forwards now. So bad fracture, no question. Urgent surgery, go forwards. Now, this is something that I've seen also. The head is in front of the pelvis. So this is inadequately, but probably best still expressed with a good old SVA. This is a nice deformity correction up there. Why is this happening? Can you explain to us where the problem is? Is this L5S1 under correction? Is this a cervico-thoracic issue? Is this an intraoperative issue, not having a pneumatic head wrist? There's a microphone for you.
That's a great question. So just grossly looking at it, her C7 S1 SVA is actually quite normal, or excuse me, it's forward. And then her C2 S1 SVA is pronounced even more forward thrust. I would have to go through the measurements, but just to my eye, this looks like the lumbar spine is still somewhat undercorrected.
Yeah, so she's off about 20 degrees.
Okay. And she looks like she has a very high pelvic incidence. If I were to measure it, it's probably, guesstimate, it's about 75, 80-ish. So I'm shooting for about 70 degrees of lordosis. And particularly L4 to S1, I'd shoot for about 40 degrees. She's 77 years old. She probably likes to live a little bit forward, and her forward gaze looks appropriate. But if you wanted to shoot for a home run radiographically, the next step here would probably be a L4 PSO.
Dr. Lin, great talk, by the way. I'll bring your microphone. Any thoughts on alignment changes here, undercorrection, overcorrection? Why did she, if you go back one more slide, I think this is such an evocative case. I always look at, what went wrong here in the initial surgery? Is this something that could have been prevented with a better surgical? Here, use this microphone.
Yeah, again, I think I'd have to run through all the parameters again, but I kind of like the gap thing is very cumbersome, but I kind of like using it because it kind of tells you what's wrong, what's out of proportion. And relating it back to the PI again. So I agree with Alekos. This PI looks high, and the lumbar lordosis doesn't look like it's enough. But where is it lacking? What's the morphology supposed to look like there? So I'd have to run through all those 4 or 5 different parameters and figure it out. But I think the problem is coming from the lumbar. It looks like.
Now, one pet peeve of mine is soft tissues. So first of all, could it be that there was a iatrogenic disruption of the interspinous ligaments at the rostral end, a dissection-related denervation, destabilization that is just invisible on our parameter obsession or obsessed assessment? And secondly, Amir, did she have connective tissue disease like RA or something that sets her up for a comprehensive failure?
No, it was. I kind of looked back through her chart, and she had recovered well from most of these surgeries and had failed at about 1 to 2 years after each of them. So usually in the patients that have soft tissue disorders, they fail pretty quickly. And so in my mind, just looking through the retrospectoscope, I think when you see successive failures, it's probably something distal that was not appropriately treated the first time.
I mean, for me, this is a patient that has a disease process called fusion disease. I'm not sure why the index fusion was performed, but at some point then this becomes an avalanche. And here we are. Is she happy with the new position?
Yeah, I mean, she's happy that she's able to walk, I think, more so than anything. But we'll see. She's very optimistic and was very grateful. So as of now, she's doing well. We'll see when she kind of pushes herself a little bit further forward. She's now not even at 3 months out, but we'll see.
It's beautifully done by you. Now, the next thing for your post-op film that I want to just editorialize is soft tissue closure. So this is a pet peeve of mine. I see so many patients with horrible appearing soft tissue splaying. They have the delta sign of trapezius winging. You can literally count the screws, the caps, the rib heads, whatever detail you want to look at, not even speaking of the spinous process sticking through the skin just about. So any thoughts, tips and tricks to reconstruct the soft tissue so they don't fall apart and splay open?
Yeah, I mean, here, and I learned this in fellowship, we are pretty meticulous with lots of PDS specifically at the cervico-thoracic junction, and as opposed to just sewing it closed, really taking the time with the fellows to put the stitches and tag them, because sometimes the reason that there's a problem is you didn't actually get the fascial layer. So really just being extra careful in that area, because there's just so much stress when the trapezius has been pulled apart. You just have to do a really good closure. And in a patient that's soft tissue compromised, I'll do a nylon closure on top of that as well.
Great. All right, Mr. Course Chairman, anything else to say? Otherwise, you want to go off to the lab again?
Yeah, I believe.
We have Yashar there.
Right.
Dr. Javidan is talking about what you just showed in principle. He's going to show it in practice. Live feed to Dr. Javidan in the lab, cervico-thoracic corrections. Do you want to quickly talk about what's next after this in terms of panel discussions?
Yeah, so I think we kind of started right here with this case. I know we're kind of moving actually closer to being on time. We can definitely skip through a couple of, we don't need to go through all of them, but I think we've been through so many general topics. It's very helpful to see some of the challenging cases that we have had ourselves and kind of go through them one by one. So I appreciate you guys bringing some cases in. So after Yashar's talk, we'll go through just some case presentations and just give us a free forum to tell you our thoughts and hear your thoughts from the crowd.